Good morning, Judy. Why don't you get us started?
All right. Good morning, everybody. Hi, I'm welcoming you to today's webinar. My name is Judy Reven. I'm from JFK Partners. I'm the Associate Director there at the University of Colorado School of Medicine. JFK Partners and Colorado Title V MCH program collaboratively present a quarterly educational series to address the current Colorado Title V MCH priorities and emerging issues, and this is part of that. So this series is intended to expand the capacity of the maternal child health, or MCH, workforce and related systems to better serve infants, children, youth, including those with special healthcare needs and their families. As I know you all know, today's topic is cognitive behavior therapy for autistic adolescents with intellectual disability and anxiety. Please feel free to type questions or comments in the chat at any point, and we ask that you keep your microphone muted. I know you all know this. We've all been on Zoom for lots of times, but keep your mics muted so we don't hear any background noise. We are recording today's event and we'll archive it on the JFK website along with other webinars in the series. We'll also post the handout for today, which you are welcome to print or save for future reference. And following the webinar, you're going to receive a link requesting an evaluation, and you can get a certificate of attendance for the evaluation. I don't know if there are any questions about any of that, but I'm going to keep going and introduce our speaker, who is Dr. Audrey Bilickley-Smith. And I know Audrey very well and have known Audrey for many, many years at this point as a friend and a colleague. And there's lots of things I could probably say, but I know you're all very eager to hear what she has to say. So I'm just going to highlight a couple of things. One is that she's currently an associate professor in our department, so Department of Psychiatry and Pediatrics at University of Colorado and at JFK. She is the primary investigator of a Department of Defense randomized trial, which she is going to be presenting on today, that examines the effectiveness of the Facing Your Fears program for autistic adolescents with intellectual disability. And that's going to be the focus of her talk. I will tell you that you will not find a more passionate advocate for individuals with autism and intellectual disability than Audrey. And I think you're going to be really excited to hear some of the, I think, really groundbreaking work that she's going to be talking about today. She's also a co-author, along with myself and some other colleagues, on our original Facing Your Fears program, the clinic-based, which is now like 10 years old, I guess, and then our new Facing Your Fears in Schools manual, which is going to be published in just a couple of weeks. So Otherwise, Audrey's also an active educator and is a training director for clinical psychology here at JFK and at Anschutz. And again, I could go on and on. She's made wonderful contributions to this field in the area and is really, as I said, incredibly passionate about working with our community and with individuals with intellectual disabilities. And I hope you're going to be really interested and excited to hear more about the Facing Your Fears IDD program. So without further ado, Audrey, I'm going to turn it over to you.
Thank you, Judy. And that was really nice. And you know how much I've appreciated your mentorship. So thank you. Can't wait to speak to you all about this topic. As Judy shared, I'm really passionate about working with people with autism and intellectual disabilities. And I am just really privileged to be in the position to be able to talk about the work that we have been doing over the past about 8 years. So this is the title of the talk. My first step here is just acknowledgments. As a non-autistic clinician and researcher, I think it's really important to acknowledge limitations in my own perspective. And first and foremost, I really want to thank the participants of these studies. As Judy shared, we've been working on Facing Your Fears for about 20 years, but for the intellectual disability adaptation, it's been about 8 years. And I have learned enormously from the families, not only about their lived experience, but what's important to them, what changes we need to make as clinicians to best serve families, and also as researchers, what is critical as we move ahead to support this population. We were funded back in 2016 by the Organization for Autism Research. And this funding was really critical because it allowed us to create some focus groups to better hear from families, from self-advocates, from family members and clinicians in the community, and begin to think carefully about how we could approach treatment. There's a lot of research out there on anxiety, but not much adapted for the ID population. And that grant really allowed us to hear more from families about what they valued. We conducted a pilot study at that time with 23 teens. I'll tell you a little bit about that. But that really set the stage for us to be able to be more competitive for a larger grant, the Department of Defense grant that Judy mentioned. I'd also like to say thank you to Judy. She was a primary investigator of the Facing Your Fear original study that's now school-based, and the rest of my colleagues here, particularly Allison Meyer, who has been a great partner in the work that we've done here. Let me move on and get started. The goal of our time today is first and foremost to really think carefully about what does anxiety look like in teens with autism and intellectual disability. So we'll spend a little time on that. I'll then pause and pull down the PowerPoint and hear from you all and hear if there are questions or experiences that you all have had in the assessment of anxiety or as a family member or individual with anxiety. We'll then jump into the adapted program and spend some time really thinking about what is core to CBT for this population. And in the context of a group-based treatment, I have found that we continue to need to adapt and tailor to the individual needs of each participant. So we'll talk a little bit about how that has taken place and how you all are probably in a similar position of really wanting things to be individualized. Okay, with that in mind, we'll jump right in. So I'm preaching to the choir here because you're all here because I think you have a shared passion for folks with autism and intellectual disability. It is really critical, though, as a field for us to recognize that people with autism and intellectual disability experience higher rates of anxiety than those without intellectual disability. So there is a unique contributory neurological, biological, and genetic foundation for anxiety in folks with autism and intellectual disability, not to mention that the world has not been crafted for people with communication differences and social differences, and that also compounds pre-existing anxiety. Where does anxiety have its impact? Across the board, and this age group is particularly vulnerable because they're at the cusp of adulthood. On the positive side, this population, this age group, the 12 to 18-year-olds that I'll be discussing today, have opportunities to really harness skills when moving on into adulthood. And I think that's in part why I feel like this age group is such an exciting age group. We see anxiety, though, impact not just social relationships, but also challenging behavior. And with communication differences, sometimes anxiety may manifest as disruption, it may manifest as self-injury, it may manifest as avoidance. And so we want to be really mindful to think functionally about behavior. What role does it play and what may it be communicating? And so that is on the forefront of our brains when we're really trying to disentangle behavior from anxiety. Despite the very high rates of anxiety in people with autism and intellectual disabilities, there is very limited access to mental health interventions. That's a byproduct, I think, of a siloed approach to autism versus mental health, but is also very much unique to the intellectual disability population. And one of the most common reports from clinicians in the community who have been surveyed about their willingness and interest in serving people with intellectual disability is that they report the lack of manualized interventions is really standing in their way from being able to provide evidence-based interventions. So this is why I think it's really critical and important to think from a research perspective what really does work in this population. But from an access issue, it's even more critical. How can we best equip clinicians in our own community to be able to serve our own neighbors, our own family, our friends best? We do best by providing them with an evidence foundation. And that really is rooted in my belief that it's important to study what's effective in this age group, in this population. The final point on this slide is really critical because it speaks to the need for resources and support. And if there are not evidence-based interventions available to families, who do they turn to? Most likely their primary care physician. And 67% of individuals with autism and intellectual disability do just that. They turn to their primary care physicians for support and are frequently prescribed medication for anxiety and ADHD. And while this medication may be extremely effective short term, the concern I think that many of us have about the use of medication long term is that oftentimes medications travel forward with people. So they often are not reduced, but rather added to. And when we think about the experience of adults, one of the gravest concerns from a medical perspective about well-being for adults with autism and intellectual disability is polypharmacy. So multiple medications with unknown side effects, with adults with intellectual disability oftentimes having difficulty expressing what those physiological side effects might be. And so this is in part why I'm passionate about evidence-based mental health supports. We really want families to have the same rights as those without intellectual disabilities and really have access to multiple mediums, multiple forms of mental health interventions, not just anxiety, depression, ADHD as well. There are lots of barriers to access to mental health interventions. And my way of trying to wrap my brain around this is to think from the individual level, then from kind of the more national level and then international level. So I'll start first with the individual level assessment. We are faced with a great deal of challenges in the field of autism because many of the instruments that we have relied upon were not crafted for individuals with autism. They were crafted for people without autism. And that right away is a concern I think many of us have. What are we assessing? And are we assessing the right symptoms, the right behaviors, and what is of value to people with autism? And so that is a huge concern, I think. A second concern is when we're thinking specifically about mental health, it's an internal subjective experience. And when we're attempting to evaluate mental health in people who may have communication differences, oftentimes we're in the position to rely on proxy reports. So that might be teachers, caregivers who might be uniquely positioned to report on what they observe, but there are limitations to those observations as they don't reflect the internal experience of the individual. And so at this stage in time, I would say this is a major barrier for us because we don't have a lot of instruments that were carved out to reflect the needs of people with autism and intellectual disability and reflect that experience. We also don't have lots of different ways to access the thoughts without questionnaire self-report. And so a huge need is also expanding the way we assess anxiety and other mental health to include other kind of mediums, visual approaches, reporting on phones through text and audio, thinking broader and wider about ways to access this experience. So the assessment challenge is huge. One optimistic standpoint is we are more aware now than before about the importance of expanding the way we assess anxiety. The other is, as a field, we're also kind of taking a step back and recognized that this is important not only for standardization of assessment, but also for self-advocacy. And so I just got back from INSAR, which is an exciting conference. It's the international meeting for autism researchers. And there was a subcommittee there, a special interest group that is called the PROMS group. Some of you may know of them. And they are developing different approaches to patient-reported outcome measures and highlighting the need to be more expansive in this approach, and are tasking the field to kind of put our heads together on ways we can better assess mental health, quality of life, particularly in people with intellectual disabilities. So more to come. The second point I have on the slide is the service cliff. So many of you may be familiar with this concept that post-high school is a period of dramatic decline of services for people with autism and intellectual disability in particular. We see a reduction of supports post-high school. We see a transition from a pediatric model of medical care to an adult model of care, with many of our young adults kind of getting lost in the system. We see changes in supports from an academic behavioral perspective outside of high school into transition periods where some people are no longer able to access the right kind of supports. And we also know that students with autism were disproportionately impacted by COVID. And so the landscape of supports is very different right now, and unfortunately has not appropriately captured all of the needs of our students with autism and intellectual disability, resulting in unmet healthcare needs. This is not just in the US, but internationally as well. But this service cliff does represent a reminder, I think, to us of the importance of really beginning to think about mental health reductions and supports and treatments early, so that by the time our students are graduating high school, they have some embedded supports. So a call to action, really, I think, for all of us. The last piece on this slide is really a unfortunate state of affairs, I think, for us in the field of autism when we look at the biases in research funding. There was a really interesting study that came out in 2019 in which a team looked at all research studies published in a 10-year period up until 2016. And results of this study indicated that the overwhelming majority of research dollars are being spent on autistic participants without intellectual disability, 94%, with only 6% of participants experiencing intellectual disability as well. And so what this tells us is not only is there a bias in terms of what studies are funded, but people with intellectual disabilities are commonly excluded from mental health interventions. And that is the number one exclusionary factor in many mental health studies, including our own for many years. We excluded people with intellectual disability. And what this has resulted in is a severe lack of evidence-based interventions for people with intellectual disability. And so without the backbone of evidence-based research, I think many families are left to kind of navigate supports on their own and have had to rely on medication management, have had to rely on other sources of support. But this does point to the overarching theme that we need to devote more attention and care to the study of mental health support and treatment. Why is adolescence such a critical time? It's critical because it's a period of time before the service cliff, right? So what we see is that high school can actually be a wonderful time period to really think carefully about goals, needs, and ways to kind of support and manage one's mental health experience. The reason we feel that high school can be a critical period is it's a time when teens are often becoming increasingly aware of their mental health. They're becoming focused on goals as their peers begin to graduate and move on to different places. And it's an opportunity really to kind of harness interest in being more independent. And so I think it's a great opportunity for us to be thinking about intervention. We also know it's critical because employment is impacted enormously by unmet mental health needs. There's research to indicate that anxiety can negatively impact one's ability to go out for an interview. It can impact one's willingness to participate in transition-based supports. And then if hired, once hired, it can impact one's ability to sustain employment. And so targeting anxiety during adolescence really does make sense and is a really important time period. On the positive, too, what we do know is that supports delivered early, sometimes even younger than 13 or 14, can really have long-term impacts that result in higher employment rates, higher salaries, and stronger social supports in adulthood. Why is that the case? I think it is quite intuitive that if you're better able to manage your physiological experience, your mental health experience, there is confidence in your ability to be able to face new challenges. And so when anxious avoidance is reduced, active engagement in the community is increased. Active coping can be generalized from school and clinical settings across other settings, and then teens are better able to access necessary transition supports. And so the adolescent time period, some people ask, why not study anxiety in preschoolers with intellectual disability? Obviously, that's important as well, but this adolescent time period and the young adult time period is just a very exciting period to really think carefully about independent use of coping skills and supports entering adulthood. I mentioned a little bit earlier that we were really fortunate to receive some funds from the Organization of Autism Research. Through those funds, we were able to conduct 4 focus groups. And through those focus groups, we were able to hear from family members, individuals with intellectual disability and autism, and clinicians about what they perceive to be valuable in terms of anxiety treatment. Through those feedback loops, we then adapted and crafted a manual that we implemented over the course of about a year and a half with 23 adolescents. This was a pilot study, so there was no comparison, but what we were really attempting to do here is hear from families, see what we could do with an adapted approach, and really reflect on what would be considered most critical in terms of a treatment, specifically targeting anxiety. One of the big kind of questions that we had in our own mind is there additive benefit to a behavioral treatment to include a cognitive component? And to this day, I think we're still in the position of really wrestling with that. Not all anxiety symptoms may require a cognitive behavioral approach. There are plenty of symptoms that can be effectively treated through an exposure-based approach alone, which I'll talk about in just a little bit. Having said that, we also wanted to be inclusive of all worries and anxiety in the context of this group. And many of the anxieties that we were assessing at this time seem to be social and GAD related, which do benefit from a cognitive behavioral approach. So results of this initial pilot study were positive in the sense that we saw reductions on the ADAMS, we saw reductions on the scared, and reductions in specific phobias. The ADAMS, for those of you not familiar with this instrument, is an assessment that was created specifically for people with intellectual disabilities. And so that was very promising and positive. The scared, on the other hand, was crafted for non-autistic youth and adolescents, and so was kind of a placeholder until we found a better assessment. And then the fear survey was really geared to look at phobias, which we know occur at high rates in this population. With that initial study, we were then able to apply for and receive funding for a randomized clinical trial. And I know not everybody is interested in research. The only reason I'm going into this a teeny bit is as we move into describing, explaining the study, explaining the individual components that we're using to treat anxiety, I do think it's important to couch this in the sample that we've used. And it's a small sample overall, 71, but the biggest sample that I know of, including only people with autism and intellectual disabilities. So while there are limitations to a small sample, it's providing us with insight about what could be possible. Within our sample, we had 71% of teens between the age of 12 and 18 identify as white. We had about 23% identify as Hispanic or Latinx. The majority of our participants did identify as male, but we did have a nice representation of females. And we had several teens identify as non-binary. We would love to see expansion of that subsample. When we looked at their cognitive abilities and adaptive behavior, we had a sample that really reflected the heterogeneity of an intellectual disability sample. So we had teens with single words. We had teens with fluent communication who reflected a range of cognitive abilities within the intellectual disability range. I want to talk a little bit about the anxiety profiles that we have come to better understand. And I say better understand because we're still not there, but it was really important for us as a team to think carefully about what does anxiety look like? A lot of people ask me, how do you know that you're really treating anxiety and not just negative affect or emotion dysregulation? And at the end of the day, we wanted to have a sense of what does anxiety really look like? And so as a means of really diving in and hearing from families about their experience with teens, we ended up using the ADIS-ASA. It is a semi-structured interview that was adapted specifically for autism by Connor Kearns. And the strength of this semi-structured interview is it really does craft questions that really target mental health in addition to behaviors consistent with autism. And it leads us to diagnoses that reflect the DSM. So we have anxiety-based diagnoses. And then we also have a series of different behaviors and descriptors that may not be formalized DSM-based diagnoses, but do reflect the experience of people with autism. And fear of change is a great example of that. That's not a DSM-based anxiety diagnosis, but rather an experience that can be more pronounced in people with autism, concerns with change, unpredictability, but really can be described under the anxiety umbrella if there is anxious avoidance and preemptive concern about change. So this was important for us as a team to really think about, because when we're thinking about intervention, as I mentioned earlier, it's important to know what you're targeting because that guides you in terms of the intervention techniques. So fear of change, for example, may be responsive to autism-based supports, visual supports, indicators of when change will transpire, rewards tied to successful change, supports tied to navigating change. But if there's a anxious avoidance, a person might also benefit from somatic management before the change takes place. And that is really what we were hoping to really better understand. Could there be additive components that we could provide families that were above and beyond the autism supports that are already available within our community? And that's what we aim to do with the Facing Your Fears adapted program. Add to what people have, not take away and say don't accommodate, but rather accommodate and add to resources available. I'm hoping this makes sense. In just a minute, I'll open it up for comments and questions, because I do feel like this is a very understudied area of work. There are very few studies that really look at the nature and flavor of anxiety symptoms in adolescents with autism and intellectual disability. It was not surprising to me to see that one of the most common anxiety diagnoses reported by parents were specific phobias. I want to talk a little bit about specific phobias because there's a lot of justified cause for heightened experience of specific phobias in people with intellectual disability and autism. So for those of you who are not familiar with the terminology of phobia, a phobia is a very pronounced fear in the presence of a stimulus. And sometimes the fear may be merited because it's painful, it's stressful, such as a shot. But sometimes it's above and beyond what you would anticipate as a fearful response. And it could result in active avoidance. It could result in fear spreading. So in other words, not just being concerned about the shot on the day of the COVID appointment, but being fearful of the hospital because of the association with the shot, fear of people related to the shot, such as people in white coats, such as doctors, fear of gloves because the doctor or the nurse used a glove when providing the shot. So oftentimes we see phobias kind of get bigger. We can identify what the onset of the fear is, the shot, but it often will generalize and spread and become bigger than just the actual fear. And in those types of circumstances, we really do want to think carefully about treatment. The other reason why phobias are really important for us to recognize in this population is because people with intellectual disabilities tend to have higher rates of co-occurrent medical complexities. So we see higher rate of genetic conditions, higher rate of associated respiratory, cardiovascular concerns, and higher rates of medication that may require monitoring through blood draws. And so the experience of people with autism and intellectual disabilities may be very impacted by an aversion to shots. And we saw a number of teens within our group who had not received requisite medical care as a byproduct of this fear of medical procedures and shots. And the final point to add to the mix is higher rates of seizures, which often need to be treated with medications, which have to be monitored too. And so the high rates of phobias is really critical when we think about healthcare support and appropriate medical care over the course of a lifetime. And it's really important too, because they often exceed and are more excessive than what we see in non-autistic populations. The good news about phobias, which I think is really exciting to share, is we see that they can be very effectively treated by systematic desensitization exposure and also by CBT-based approaches, and can really open doors for people in terms of access to other opportunities such as good medical care and other transition-related supports. So the fact that phobias occur at such a high rate is important to acknowledge from an assessment standpoint, but also important to be able to treat early on because they tend to persist without appropriate treatment. The next diagnosis I'd like to jump into a teeny bit is social anxiety and social fear. We see social fear occur at very high rates, and in part this could be due to, as I mentioned earlier, the world not being set up for people who are neurodiverse, expectations being high, not quite knowing how to reconcile my skill set with the demands of the environment, not quite knowing what to say, how to navigate a social situation. We see heightened rates of teasing, bullying for people with autism that can be very difficult and harmful from a long-term perspective, traumatizing. And then we also see challenges in terms of segregation and exclusion in our educational system and in our mental health system that kind of perpetuates a sense of lack of belonging and lack of community. And so it's really important, I think, for us to cast a wide net here. This is not just an issue of an individual experiencing social stress. This is an issue of us contributing, I think, to difficulties that people with autism experience, in part from a societal perspective of exclusion. And so we want to be mindful of this because treatment is always twofold. It's supporting the individual in being able to manage their experience, but it's also identifying positive social environments in which people feel a sense of community and a sense of fit. And it has to be kind of a two-part process. So yes, we want to impart a sense of empowerment on the individual that they are able to manage the stress, that they do have the skills necessary and be able to teach those skills. But we also want to be mindful of the situations in which they're in and really think carefully about ways to create opportunities for people to feel successful. The generalized anxiety domain is up next and was the second I should rephrase that. Along with phobias are the most common clinical diagnosis for our families to be reporting. And I think what is very interesting about this is for many years, I think the cognitive experience of people with intellectual disabilities was kind of downplayed with an overemphasis potentially on the experience of specific fears and phobias and the underestimation of the toll from a cognitive standpoint the anxiety is taking on many individuals with autism and intellectual disability, both from an anxiety perspective and from a social perspective. What was very interesting for us to learn over time about the fear structures of people with generalized anxiety in our own study, and I want to really cushion my reflections to the experience with these teens within the study, was that a number of these fears really were future-oriented, tied to their ability to be successful and navigate the demands post-high school. Lots of fears tied to what will happen when their caregivers pass away. Will they be able to live independently? Will they be able to drive? Will they be able to function on their own? And then other kind of fears tied to the experience of being neurodiverse and appearing different, looking different, not being able to access similar experiences like college, like employment. So diffuse kind of worries that were ingrained. And then other kind of rumination experiences tied to letting go of past events. So we have those kind of future-oriented fears. And then we have those rumination experiences in part tied to that perseveration of negative experiences and challenge being able to move past experiences that were harmful and difficult. I have a picture of a cell phone charging because I found it very interesting that a number of the teens we worked with had fears of technology either being removed or not being charged. And we had a number of teens have backup chargers, get stressed when phones, iPads went below 90% charge rate. And I really initially thought, gosh, this might reflect a over-reliance on technology. I came to find, though, that when technology is your central communicative means of accessing social supports, accessing your world, that there is a very natural fear tied to not having access to that, having that removed. The question for us was, did it go above and beyond that kind of naturalistic fear, and did it become problematic? It was only when it was interfering in teens' ability to kind of navigate their day, make use of the educational or social opportunities in the present that we actually targeted it. The last fear I have identified here is separation. And we saw higher rates, obviously, than you would expect for an adolescent population. We see separation anxiety persisting far beyond the age range that would be considered typical, which is typically, we typically see declines around the age of 6. But we also see that separation persists in part due to a reliance on caregivers to support emotion regulation. And I think this is a really interesting point to highlight because part of our goal over the course of treatment is thinking really carefully about what is it about separation from the caregiver that is particularly challenging. And one of the challenges that really came forth over the course of the past 3 years that we've been really digging in deep is what does a caregiver represent? Oftentimes, a caregiver represents advocacy, soothing, comfort, and security. And how can we think about replacing that? We can't replace that, and we don't necessarily want to replace that. But how can we support a sense of competency and self-efficacy in terms of the teen's ability to begin to manage those symptoms? And by managing the physical symptoms of worry, we do tend to see a reduction in separation anxiety as teens' ability to be able to take deep breaths, manage the expectations of their environment increases, so too does separation anxiety decrease. Clearly, we needed to have an exposure-based approach as well so that teens had opportunities to be brave without their caregiver. But I want to highlight this because I think it is somewhat unique to this age group and this population. And it really does open the door for us to be thinking about ways to increase self-soothing, self-calming, self-regulation really early in life, in part because it does take quite some time to really effectively address these challenges. So that was my summary of the findings that we had as a byproduct of conducting the ADIS ASA. And once again, that's the anxiety diagnostic interview with the autism addendum. I'm going to move on and talk a little bit, sorry, my slides are not moving on, and talk a little bit about a recent review about research. And this is this was a project that Allison Meyer, a colleague, took on. She looked at, does anxiety look different for fluent language communicators versus those who have minimal verbal abilities. And we had a subset of adolescents who had single words or phrase speech. And we compared their anxiety diagnoses to the diagnoses of teens with autism intellectual disability who had fluent communication. And it was not surprising for us to be able to see that we see higher rates of generalized anxiety and social anxiety in those teens with fluent communication. And what is really interesting for us to reflect upon is, why is that the case? Is that because they are fluent communicators or more effectively able to communicate their internal experience? Or is it that those teens with minimal language have a different internal experience and may have more pronounced anxiety in other domains that are not tied to social situations or generalized anxiety? We don't know. What I will say is I do feel like this points to the need to better support teens with minimal verbal language in being able to express their internal experience so we have a better sense of what that is. It's also really interesting that we see slightly higher phobias, but not clinically significant differences across minimally verbal teens and those with fluent language. So what this tells us is phobias tend to persist irrespective of language use. Same with separation. We still see high rates of separation across those individuals with fluent communication and those who would be described as having single words or phrase speech. We also just recently looked at the parent experience. So parenting a complex adolescent with autism and intellectual disability can take its toll. And the reason we have embraced a group dynamic and group treatment is in part because in those early focus groups, parents shared with us how parenting can become a very isolating experience. And we wanted to think carefully about ways to provide support to parents and also to think carefully, are there additional contributors to burnout for parents with adolescents with autism and intellectual disability? And I was really interested to see that challenging behavior on the part of the teen, so self-injury, aggression, disruptive behavior, did not predict burnout. High rates of anxiety in our population did not predict burnout. What we saw as more predictive of burnout is parents' own self-report that they did not feel effective managing their teens' behavior. So it wasn't the actual behavior, it was their perception of how effective they felt managing their teens' anxiety and managing rigidity or obsessive compulsive features. And so I think this is interesting because it does point to the uniquely complex role that rigid and obsessive compulsive behaviors play. And it also kind of is guiding us in the fact that we might need to uniquely tailor supports to parents who are parents of kids with that profile to manage those kind of behaviors and feel efficacious in terms of the supports they provide. I shared these results at INSAR, and it was really interesting for me to speak to other researchers, clinicians, and self-advocates about this concept of burnout. And it's a very loaded term, and I want to acknowledge that. There is some concern about talking about the burnout experience as a byproduct of autism. And I want to be really clear that this was not the angle we were going in. The angle we were going in is recognizing that parenting a complex child can be hard and it can take its toll, and supports both from a parenting perspective and also from a self-advocacy perspective. How can we support teens in being able to feel successful in managing their own kind of mental health experience is really kind of the way to go. But I do want to acknowledge that the terminology may be fraught with some challenges here, and we may want to think more carefully about the way we're describing that experience. We're getting closer to talk about the strategies here, but before we do that, I want to acknowledge that when we look at what is out there already from an anxiety standpoint, what we see is best practice in the treatment of anxiety for non-autistic youth. Our use of approaches such as cognitive behavior therapy, the coping cat, coping kids, all have been adapted to meet the needs of individuals with autism. And then some programs have been specifically carved out to be tailored to children and youth with autism and other kind of learning needs. The Exploring Feelings program from Tony Atwood has been out for some time and takes a psychoeducational approach to managing anxiety with visual supports. The Massey program by Susan White is really focused on supporting social connection and community while also managing the internal experience of anxiety. So for those of you not familiar with that work, it's worth checking out. The Facing Your Fear program, led up here by Judy Reven, has taken a group-based approach, and as she mentioned, is now school-based. That manual's coming out in 3 weeks' time. And part of the reason we're thinking carefully about when do you adapt, when do you not adapt, is when there's a dearth of clinicians who have expertise in manuals, how can we think about using the manuals that are already out there for clinicians and have clinicians use their own judgment about how to modify and adapt? And I think the message that really does need to be out there is that is good and that is great, and that often is the best way to go. If there's not something that was created already, clinicians really, we're all in the position of needing to kind of carve out approaches that may be modifiable based on what has been out there already. From a family perspective, that might mean using clinicians' expertise, even though they may not specialize in autism and intellectual disability, but trying to think carefully about ways in which they can continue to support the family unit, although not from an autism perspective, but from a mental health perspective too. The common CBT components across the majority of studies have been psychoeducation, which is teaching your body how to manage anxiety, how to manage the physical symptoms, teaching your brain helpful thoughts, and then facing fears a little bit at a time. The one program that is a departure from that is the EASE program. And the EASE program specifically uses mindfulness-based approaches as opposed to exposure, but mindfulness-based approaches for people with intellectual disabilities and autism. There are 3 other programs I'm excited to share with you a little bit about that I didn't put on this slide, in part because they're not anxiety specific, but there is a program led by Andrew Jahoda from the University of Glasgow on behavior activation. It's been modified for people with intellectual disability, and that's coming out soon, and modified for adults by Vanessa Ball at Rutgers. So that's really exciting to be thinking about. And then other programs are looking at carving out modifications to tackle depression as well, not just from a behavioral activation standpoint, but from a cognitive standpoint. This will be my final slide before I pause. The framework in which we consider whether or not anxiety is part of an individual's profile is evolving. And in 2015, Connor Kearns, a psychologist at the University of British Columbia, crafted a framework that really highlighted the need to identify symptoms that are excessive given the teen's developmental skill set. And the reason I highlight that is I think we're always challenged. what is typical for a child's developmental level. So if a child is developmentally at a 4 or 5 level, would separation from a caregiver be excessive? Maybe not. Would that guide our decision making about treatment? Probably. So that component of excessive can really help guide us about whether or not we should be thinking about autism supports versus mental health supports, whether or not it gets in the way. So to what extent is this anxiety kind of taking over and spreading? Is it getting in the way in school? Is it getting in the way in social? Is it impacting overall family functioning and well-being? That is a hallmark feature of a clinical diagnosis of anxiety. And is there anticipation or avoidance? So anticipation with distress can come in the form of avoidance, but for those teens with minimally verbal communication skills, we really want to look at the behavioral framework. And is anxiety above and beyond what we would be expecting from autism alone? This framework is helpful, but it is still challenging to kind of disentangle. At the end of the day, what I would say is we think about referring people for anxiety treatment in part because of the interfering nature of the symptoms. So I would encourage any of you, if you're feeling like you're not quite sure, is this anxiety? Is this active avoidance for other kind of functional means? If it is getting in the way, if it's excessive, and if it's taking over, I really do encourage a referral for anxiety-specific treatment, because I feel like anxiety-specific treatment has been proven to be quite effective, and we are able to see increased engagement. I'm going to pause and open the chat up, or unmute and speak out if you have comments or questions, because I'm going to transition in a couple minutes to target specifically the intervention. Any comments or questions tied to the assessment component? And if not, I'm happy to jump right back into the intervention. I'll leave it open just for a minute. Okay, I'll jump right into the intervention, and then we can do questions at the end. Thanks, everybody, for reflecting now. So the sample of teens that we have included have been between the ages of 12 and 18. As I shared, we welcome all communication levels, and we welcome all behavior within the context that is manageable in group. We did not want to exclude teens because of disruptive or aggressive behavior, but we did want it to be manageable within the context of group. And the reason we really try to widen our inclusion criteria is oftentimes behavior that could be perceived as challenging could be reflective of anxiety. The inclusion of caregivers is really a sticky point for some people. And the reason in part that we wanted caregivers to be included in every aspect of our treatment is in part because of the long-term role that caregivers play in parenting teens with autism and intellectual disability. Research does indicate that 87% of autistic adults continue to live with their caregivers during those early adult years up until about 30, and sometimes significantly longer than that. And so from a caregiver support perspective, we thought including caregivers could support generalization, but it could also support a shift in conceptualization of what could underlie behavior, and it could support implementation and advocacy with school and transition-based programs. The reason I spent some time describing that is in part because when we think about adolescents, it is tricky to know, to what extent should they have their own time in their own space? And for some teens, I really feel like having caregivers was not the best. They wanted their own space. But for the purpose of consistency across the program, the overarching benefits we thought of including caregivers kind of outweighed some of the downsides. The core components are similar across most CBT treatments, but really were adapted heavily for the intellectual disability population. So psychoeducation reflects the importance of understanding the cycle of anxiety. When you avoid and you don't have well-developed coping skills and negative thoughts, that cycle of anxiety tends to continue. What we want to do is intervene on the level of managing the physical symptoms, which is what we call somatic management. So manage your body's reaction. We talk broadly about emotion regulation in general because we feel like sometimes it's hard to know exactly what the anxiety trigger is, and managing one's emotion kind of supersedes the specificities of the stimulus or the trigger. And then really thinking carefully about the way we interpret stressful situations. And cognitive supports for this population are really understudied and underexplored. And we have yet to know the true benefits of cognitive supports. But from a qualitative standpoint, what I have noticed is you change the way you talk about something, you change the way you feel about it. And lots of teens might use perseveration and repetition tied to feared situations, and lots of caregivers reinforce inadvertently those negative cognitions by excessive reassurance. An example of that might be a child who is afraid of shots. I'm sticking with that theme because it's so common. Lots of caregivers will tell their kid, no shot. This is a talking appointment, no shot. But what that does inadvertently is reinforce the fact that shots are scary, shots should be avoided. And so we really want to think about replacing that language with coping language. You can do it, you can handle it. And it's okay to say it's a talking appointment, but you don't want to emphasize the absence of shots because at some point they will come into play. We modified the modality, as I mentioned. We did modify the sessions and the content. So I'll get into details tied to each of those. So what we ended up doing in this program was front-loading parent content. So we had 3 sessions that were parent-only, 90 minutes before teens and parents or caregivers came in person to our clinic for the remaining 11 sessions. In those first 3 sessions, what we really highlighted are what factors contribute to anxiety and emotion dysregulation. We have a good sense now of what the primary triggers are for the general population of teens with autism and ID.
So I don't forget, Zoe.
But what might that look like specifically for their teen? What do those physical symptoms look like? How can we differentiate avoidance that might be a byproduct of anxiety from escape avoidance or avoidance because of challenge? And we really try and highlight the difference between the two are the physical symptoms. So anxious avoidance tends to be paired with physical reactivity, whereas avoidance that would be described as non-anxious avoidance does not always have those physical symptoms. That's a complicated process, so we have to kind of tease that apart. Our message to families was not that we should eliminate accommodations, but rather build accommodations, build skills, but also know the time and the place to do exposure. Not all fears require exposure. We really wanted families to pick a fear that was really getting in the way for their family, and then think carefully about how to accommodate other domains of anxiety. So I really want to highlight that because I think there's this important message that we all want to kind of embrace, which is how can we create environments and communities that pull forth skills. In some ways to do that or to think about accommodations and supports. But when do we want to push accommodations aside and build up exposure and tolerance to distress in specific situations in which that anxiety is getting in the way? So that's kind of the hallmark feature. And then from a caregiver perspective, part of our goal is to think about burnout prevention. How do we think about burnout prevention? It's critical to think about perceived support. And perceived support is different from actual support. It's thinking about what does the individual perceive to be helpful. What I find helpful is different from what you find helpful. Recognizing that and thinking about ways to kind of build community when anxiety isolates. Anxiety results in avoidance, which results in isolation. And for families who have already been kind of disenfranchised from educational and mental health service system, our goal is to kind of expand support rather than decrease it. Visual structures were critical for every aspect of our session. We started off with 2 different curriculums, a curriculum for fluent communicators, and then supports and visuals for those teens with minimally verbal language skills. We ultimately ended up converting and removing a lot of language and using more visuals because it's a universal kind of medium. I just wanted to highlight that because that was my own dilemma. How do I kind of meet the needs of complex, heterogeneous communicators? And ultimately, having a more universal design was a way to go. How do we think about teens' own ability to communicate their emotional experience? We used a system that many other people use as well, the red light, yellow light, green light system. And part of our reason in using this was because many teens were familiar with it already. Lots of curriculums use it. We're not trying to reinvent the wheel. But what we wanted to do a little bit differently than what we would do for teens without intellectual disability is use pictures and visuals to have teens kind of sort through different pictures of anxiety-provoking situations so that we could begin to know what to target. What was red zone, high anxiety? What was yellow zone, mid anxiety? What was green zone, relaxation? And then we could create a crisis plan. For red zone triggers, how do we manage? We manage through taking a break, reducing language, and visual methods of calming the body. And that was the number one lesson learned. Do not attempt to intervene through talk when kids are in the red zone. So that was a big message that we have learned over the past 3 years. Rather, come up with nonverbal ways to maintain safety. Yellow zone is a period for instruction, for use of somatic management techniques and for cognitive techniques. Red zone is for being safe and for caregivers, clinicians, teachers, modeling, deep breathing, safe choices. And then over time, we added strategies based on each individual profile. When we think about best practice in somatic management, deep breathing is a number one choice across all studies. And in part, that is because the physiological experience can be really transformed through oxygenation. And deep breathing is very easy to teach and can be effective. We really encourage people to move away from language such as take a break to rather calm your body, so that it was more empowering and really reinforces that concept of you can do it, you can handle it. Visual menus were really core and embedded within daily routines. When we think about best practice for people with intellectual disability in acquiring self-soothing and self-calming skills. It's repetition, it's embedding within natural routines, and it's providing visual structures and supports. The 4 strategies that we trialed and landed on after exploring a much wider range was number 1, the deep breathing, you see the globe. Number 2, senses. So mindfulness-based practice with visual accompanying approaches. Progressive muscle relaxation. We have the squeeze ball here, but we have a larger kind of progressive muscle relaxation. And then chair yoga with visuals for each page. My experience with those teens who we would describe as having single words and phrase speech is they tended to navigate and do best with the deep breathing and the chair yoga, in part because of the structured nature. We used other types of deep breathing techniques. This is a respiratory aid, a respiratory exerciser. Lots of the teens liked the visual component of seeing the balls rise up and then flipping it and seeing them go down with the exhale. And then other kind of, once again, we're not trying to reinvent the wheel. We want to take advantage of other evidence-based approaches to teaching deep breathing, and lots of you are already familiar with this. The key for us with deep breathing was ensuring that the exhale is longer than the inhale, that there's not a rise of the shoulders, but rather that the lungs expand capacity, and that it is done systematically across the day so that it becomes rehearsed and learned. I'll go to is 3 deep breaths, but obviously you can use as many as you want. But creating visual books tied to deep breathing and chair yoga was particularly helpful for those teens with single words and phrase speech, because they really seem to understand not only the visual support, but the modeling. Replacement of negative self-talk, I think, is a very controversial topic in the world of intellectual disabilities, in part because the concern is, how do we know what we're tackling? And we don't. We have a clue based on perseveration. We have a clue based on what the individual might be echoing. And we have a clue based on caregivers' own pull for reassurance seeking. But it's very difficult to know confidently, for sure, what those negative cognitions are. So instead of really trying to target through a lot of more sophisticated or advanced cognitive restructuring, we really focused on replacement and on very brief phrases that highlighted self-confidence. I got this. I can do it. The most common phrase that families ended up selecting was, I'm brave. And I love that because it really speaks to that identity. I got this. I can do it. We encourage caregivers to state it in the first person. I got this. I'm brave, in the event that their team would echo that. Visual structures, again, can be very helpful. And to be clear, not everybody needs a visual structure, but when it comes time to the teaching component, we really believe that the visual structure sets the stage for use. But for many of the kids with single words or phrase speech, doing videos in which they use it, they watch themselves, was really powerful. They really like to see themselves confidently state, I got this. So really thinking about ways to use video as well. All of this is building up to number 3, be brave. So creating a structure that is clear, that is visual, that is repetitive, was really our best method of embracing exposure. It is very challenging if a person is not coming to us saying, I want to face my fear of a blood draw. And then we are encouraging exposure. So we really wanted to have families identify that and have teens understand the structure so that being brave was one component of this exposure. What this pie chart does is it highlights the primary exposures that families opted to complete over the course of treatment. And you'll see that they reflect the anxiety diagnoses that I shared before, but the most common fear that people wanted to address in the context of group was social, followed by generalized anxiety, followed by separation as well. And we did have a number of families want to tackle specific phobias too. The decision making tied to what fear we should break down and face through exposure, which is breaking a fear of a bloodshot into tiny little steps, was really the task we asked parents and teens to do together. Some teens were not able to do that and could not communicate what they wanted to face. Some teens were. So what we really tried to go is with the fear that the teen identified themselves. For those teens who were not in the position that they were able to identify the fear that they would face, we really deferred to the parents. And we tried to make that decision based on the impact of the fear, the level of interference, and what could potentially be accessible to them if they were able to successfully get over this fear. The issue of motivation for change is a really tricky one, and teen buy-in is important. We want teens to have a voice. We want teens to be able to say, this is what we want to do. At the same time, we also don't want to deprive teens who are not able to give voice to that goal of the opportunity to engage in exposure, because we know that exposure is ultimately what makes the biggest difference, and the biggest area of change is just being able to face your fear a little bit at a time. And so I share this with you just as a dilemma that we faced over the course of treatment. How do we support exposure? How do we support motivation for change so that this is something a teen is engaging in together and not something imposed upon them? And it's, I think, a dilemma that we face. Visual supports, though, I do feel like we're powerful in being able to support teens and having predictability of the experience. As I shared before, we try to be very concrete and systematic. First, I'm going to take 3 deep breaths. Then I'm going to remind myself, I got this. And then I'm going to look at the purple glove for 5 seconds as a means of getting over my fear of the bloodshot. And then I'm going to have a reward. So we would do approximately 5 to 10 exposures per session. Those are quick exposures, and sometimes it would be longer depending on the nature of the exposure. But the goal was to be very systematic, repetitive, so that there was predictability, and so that teens would know how will I know this is done once I get through this structure. We recently completed exit interviews with families and completed qualitative analyses, really to listen carefully about the overarching theme from the feedback. And the overarching theme, there were 4 themes that kind of came forth from caregivers who completed the treatment. The connection between CBT and self-advocacy came forth. And you've heard me kind of talk about this. A big goal over the course of treatment was to support teens' own ability to be able to manage symptoms of anxiety, and to empower teens that they are capable of managing their anxiety. And so that theme came up from caregivers over the course of the exit interviews. A second theme that emerged was that we weren't sure, like, would teens who reflect the full intellectual disability spectrum be able to make use of somatic management and helpful thoughts. And what parents really shared with us is not everybody was able to make use of the helpful thoughts, but what the change in replacement did was it kind of carved out a new pathway for experiences that were different and that were tied to this sense of competency. I got this. So instead of saying no shot or no dog, you got this, you can do it, creates a new neural pathway of competence and coping in association with coping strategies that families reported was helpful, even though they were never super confident that their teens always understood what that meant. And I think that's kind of interesting. The third theme that arose was that caregiver involvement really helped support accessibility of the approaches and generalization of approaches to other environments. And that was of interest because I feel conflicted, quite honestly. At times I feel like teens should have their own space without a caregiver. But when you're thinking of a group treatment, you're thinking about the overarching majority, and the overarching majority did appear to report that caregiver involvement was of use. And then the final theme are benefits and challenges of a group modality. A benefit that was really shared was the sense of community, the sense that I'm not alone, that others are experiencing the joys and challenges of anxiety, intellectual disability, and autism. The challenge was that some parents felt like, even here, I don't belong. And that is an issue I think we are really trying to carefully consider. When you're in a group that is designed to kind of meet the needs of a group, by definition, some people might not feel like they are being included to the max. And I do feel like for some families, that was difficult. They felt like their teen was not similar to other teens in the group. And some families reported that they felt like individual treatment would have been a better modality for them as a result of that. The final piece to mention is we also looked at group involvement and attendance. And we examined Jenna Eilenberg, a psychology intern with us right now, and took the lead on this. And she examined factors or variables that could impact attendance and participation in group. And she looked at distance from clinic. It's really difficult to get to a clinic in person. At the same time, it's very difficult to deliver a telehealth intervention to individuals who have different communication abilities. And so we were feeling kind of challenged by this issue. So she looked at distance from clinic. She looked at medical complexity of the teen. She looked at family income, status of whether or not there was one caregiver or two caregivers in the home, and mental health complexity to see what impacts were significantly related to attendance. And of those factors, the only variable that came out as significantly impactful on whether or not a family was able to attend maximum number of sessions was caregiver status as single or with a partner, with caregivers who identified as being single being less likely to attend and maintain participation in group. And I think this is really important as we move ahead, because we're really trying to think carefully about how can we increase access to care. And for those parents who are single parents or who don't have a partner, it really is leading us to be thinking about implementation in other settings to support access. So although it's too early, our next project really, I would like to be in transition programs in the 18 to 21 year old programs, so that all teens have access to supports tied to emotion regulation and anxiety management. Our final thoughts here, it's critical to expand the mental health interventions. I think I made that clear. We think that exposure ultimately is what is most beneficial. It doesn't seem like the somatic management and helpful thoughts alone are able to result in change. It really does seem like that exposure is what brings about change. It's encouraging to think about the use of both somatic management and helpful thoughts, although to be completely transparent, we do not know to the extent what each of those factors contribute to reductions in symptoms. And we don't know who benefits most from what strategies. And that really is kind of the next phase. I appreciate your time and would love to hear if people have questions or comments. I see some questions in the chat. Alicia said, a lot to take in and reflect. Thank you for saying that. Please feel free to email me if you do have later reflections. I'm happy to communicate more and hear your thoughts. CBT with kids with ID, can you talk a little bit about how for the modifications? So the modifications were twofold. One, creating predictability and routine through visual means and repetition. So as you saw, we use that visual menu of somatic management. And I think the biggest challenge that we have witnessed is somatic management, take a deep breath, is primarily used as a reactive strategy as opposed to a proactive strategy. So what we are really trying to do is preemptively encourage managing the body over the course of the day, systematically, consistently, repetitively, before there is a rise in elevation up to the red zone. Once you're in the red zone, it's crisis management, it's thinking, get people into safe places, it's reducing verbal communication, and it's modeling somatic management. It's showing people how to deep breathe without the verbal output. The other modification is, instead of active problem solving, like many people are pulled in to do, it's using helpful thoughts that highlight competence. I can do it, I got that, as opposed to elongated problem solving, because elongated problem solving results in a language overload that oftentimes increases anxiety and stress as opposed to decreasing anxiety and stress. There is a time and place for problem solving, but it should not be in the yellow or the red zone. And we think about yellow and red as being when, as soon as a person is nervous, edgy, frustrated, or escalated. So really highlighting the need to remove language, remove problem solving, and replace with repetitive somatic management techniques and very brief helpful thoughts. I'm going to keep going. Is this part of a curriculum? Yes, so the original Facing Your Fear treatment manual was published in 2011. There is a school-based manual that is going to be published in about 3 weeks' time, but the adapted version for intellectual disability is not published yet. We still are in the early stages. We still have to analyze our results and see if it's effective before publishing. We also have to hand the curriculum and the manual over to other kind of groups to see how they do with it, what modifications they might add to it as a part of just good clinical practice before publishing. You want to publish a program that has an evidence base behind it, and we're not quite there. What else? Do you have advice on how much time to give a teen who is in the red zone before they might accept verbal input? That is really a great question, because I think oftentimes we jump in too soon. And what we've tried to do is kind of trial and error. We want the teens to be able to give us feedback on this, and we try and systematically modify that. So using your observation, if you feel like an episode of agitation might be 10 minutes, then you might want to go for 11 minutes before beginning to use the calming approaches. So it is based on behavior observation. You want to have it extend a teeny bit beyond the yellow zone so that the brain is more open to approaches and not escalate again. Jamie Brunner, it's good to see you and hear you. Thanks for your comment. How do you handle exposures in this population if they engage in aggression or SIB? That is an excellent question, because what that indicates is it's too hard of a step. And that absolutely took place for us some of the time, that the step that we identified was either too challenging or the person wasn't in a good state in that moment. So typically if aggression took place, then it's stepping back, stepping away, getting back into the green zone, and moving way back. So if we're if the exposure step was say looking at blue gloves because of the association with the shot, and that was too triggering, then what that tells us is too hard. What is an easier step that might be a little bit less evocative or less stressful? So in the easier step really has to be determined through collaboration with the caregiver and through your experience with the individual. But what we try and do is step back and then step down. So move down the chain of exposure to an easier step. And then think heavily about rewards, making sure that that flow chart of calm body, calm mind, be brave is maybe practiced with easier things that are not super stressful, that might be more green zone, so that the individual understands reward, heavy reward, and emphasizing the reward component, and then gradually shifting into something that might be a little bit harder. But I hear you. I think it's been very challenging for us when aggression is part of the profile. Other comments or questions? I think actually we might be out of time. Christine and Dina, are we out of time? I'm going to put my email in the chat.
We are over time by just a couple minutes.
Okay, I'm going to put my email so that people can reach out to me if you have questions or comments or other kind of considerations. Really appreciate your time today, and very interested in hearing if you have thoughts for me about next steps. Thank you so much for your time.